next session of Teachers Talk in Uvea Session 1. It's my privilege to invite on dais Dr. Jyotirmay Vishwas, our chairperson for the evening, and Dr. Santosh Mahapatra, co-chairperson Dr. Amitav Kumar, along with convener Dr. Samiksha Agarwal and co-convener Dr. Debashis Das. We shall be learning a lot about this inflammatory condition, and we hope that we won't be inflamed much. So without much ado, I invite on the stage Dr. Vijay Pratap Singh Tomar, and he shall be enlightening us with certain pearls and insights into the pediatric uveitis. And he has another talk on immunosuppressive agents in uveitis. Pediatric uveitis, as we all know, is very difficult. So we look forward to your talk, sir, and hope to learn more.
So thank you so much, Dr. Ghazal, for your kind words. Thank you, AIOS, for giving me this opportunity to be here. Second one. So good evening, everybody. Children represents a very special and interesting subgroup with regards to the diagnosis of uveitis and its management. And since they are having lesser complaints and the symptoms are very few in number, they present to us very late. And by that time, the disease has already established inside the eye. Since we are having limited treatment options because steroids are very much prone to cause growth retardation as well as mental retardation, and this age group is very much prone to amblyopia, so the visual rehabilitation is very much guarded. That's why I have decided that we will discuss this topic. The prevalence of pediatric uveitis is 2.2 to 21.6% worldwide as per the literature available. Anterior uveitis is the most common type of uveitic entity, ranging from 1/3 of to 3/4 of the total uveitic patients. Juvenile idiopathic arthritis is the most common type of etiology behind anterior uveitis, and in intermediate uveitis, still the etiology is idiopathic in nature. There is a long list of etiologies behind posterior and panuveitis. Now coming one by one. Juvenile idiopathic arthritis is responsible for the 47% of the total cases of pediatric uveitis, and GIA is of three types: posi-articular, polyarticular, and systemic. Systemic GIA, there is no ocular manifestations. In India, posi-articular arthritis is found to be the most common among GIA. And this disease more commonly affects girls, and the mean age of presentation is usually 2 years, but it can be seen as early as at the age of 6 months. 75% patients are ANA positive, but in India, it doesn't hold true. If a patient is presenting at an early age onset, if he's a male, if he's ANA positive, HLA-DR5 positivity is there, and on first slit lamp evaluation, posterior synechia is present, it is going to be a bad prognostic indicator. Most of the patients are asymptomatic, eye is perfectly white. So most of the time they present as a chronic patients. That's why the complications in the form of band-shaped keratopathy, cataract, glaucoma, and CME are there. Initially, they should be treated with topical steroids along with cycloplegics, but to achieve the complete remission, we should go ahead with the oral steroids, but we cannot give them for a longer duration, so it is better to go ahead with the immunosuppressive agent. Sarcoidosis is considered to be a disease of old persons, but sarcoid can affect kids, and there are two types of presentation: early onset and late onset. Early onset, kids are affected below the age of 4 years, and they are characterized by skin rashes, uveitis, and arthritis, and because of that, they are most of the time misdiagnosed as GIA patients. But in sarcoid arthritis, the joints are swollen, boggy, there is no pain, and movement of the joints are minimally affected. Parotid involvement is more frequently seen in kids than in the adults, and the most common presentation of sarcoid uveitis in kids is granulomatous anterior uveitis. One thing that we will have to consider while evaluating these patients, that leukocytoclastic vasculitis is more common in kids than in the adults. While evaluating the investigation reports, Serum ACE titer and lysozyme titers, they should be monitored very cautiously because they can be falsely positive elevated. In kids, they are higher on the side. In the cases of diagnostic dilemma, it is better to go for the lung or lymph node biopsy. What is happening? They are managed by the means of topical steroids and cycloplegics, but sometimes in the cases of intermediate uveitis, sarcoid can present like that, we will have to take the help of periocular systemic steroids or immunosuppressive agents. Now one more important differential should be there, that is TNO. It occurs because of the insult from some microbial agent or because of some drug, and these kids usually presents with uveitis along with fever, malaise, flank pain, hematuria, proteinuria or pyuria. Uveitis can occur before, simultaneously or after nephritis, and again the females are more commonly affected than the males, and the mean age of presentation is usually 15 years. It can be unilateral, TNO can be bilateral, it can be granulomatous, it can be non-granulomatous, but it responds to the steroids and immunosuppressive agents, but you will have to put your patient on long-term follow-up because ocular destruction is more than the renal destruction in TNO. Now coming to the intermediate uveitis, 90% cases of the intermediate uveitis are idiopathic in nature, and intermediate uveitis constitutes 1/6 to 1/4 of the total uveitic entities in the pediatric subgroup. Spillover anterior uveitis is more commonly seen in kids rather than in adults, and most common complication of intermediate uveitis in kids are cataract and cystoid macular edema. Systemic association of intermediate uveitis are there, but multiple sclerosis is rarely seen in children. But you should consider that if it's a female patient who is having bilateral intermediate uveitis with DR15 positivity, then you can think it can be associated with this multiple sclerosis. Most common pattern of intermediate uveitis is a prolonged course without exacerbations, and we follow here also modified Kaplan approach, but with a little difference. After, if a patient is not responding to periocular steroids, it's better to switch over to oral NSAIDs like naproxen, then you should plan for the oral steroids. Now coming to the posterior and panuveitis. Toxoplasmo retinochoroiditis is the most common infectious uveitis, and toxoplasmosis can be congenital and acquired. In the third trimester, the highest transmission is there, but the maximum damage to the eye is done when it is transmitted in the first trimester. We all know that sabintestride is seen classically in congenital toxoplasmosis, and headlight in the fog appearance is typically seen in active lesions, whereas cartwheel lesions are seen in the old lesions, and most of the time in pediatric subset, these are incidental findings. In infants, IgM is of some help, but in adult patient, it is nested PCR along with Goldman-Whitmer coefficient. It can be helpful, but the diagnosis of toxoplasma is mainly clinical in nature, and we treat them with triple therapy, one sulfur drug, one non-sulfur drug, and corticosteroids. In recalcitrant cases, you will have to take help of your friends, VR friends. Toxocara, again, you will have to suspect if it is, there's a history of contamination of food with dog and cat species, two types, visceral larva migrans and ocular cysticercosis. You will have to rule out retinoblastoma because the age group and the presentation like leukocoria is seen in both the patients. Again, the diagnosis is clinical. If it is peripheral, simply observe. It is a posterior pole, go for periocular and oral steroids, but never start anti-helminthic drug if a live motile helminthis is seen there. Tuberculosis, very common in India, but in children it is highly uncommon, a little less common. Now, this is the case when I was a resident under JB sir. It was an 8-year-old girl who presented with hypopia and uveitis. Battery of investigations done, not responding to topical steroids, then switch over to oral steroids, not responding, then I went to sir. Sir did IAC tab, sent to cytology lab, and it was found to be a case of retinoblastoma. So beware of masquerades. They can be there. So the take-home message is meticulous history along with clinical, systemic, and ocular evaluation is a must, and we will have to achieve complete remission. I am very much grateful to my teachers, JB sir, SKG madam, Amla ma'am, Sudarshan sir, who taught me the nitty-gritty of uveitis. Thank you so much.
Thank you so much, sir. Thank you so much, sir. It's indeed a very difficult subject to cover up in 7 minutes. Pediatric uveitis in itself is a very challenging case because they don't present with a red eye. They present mostly with a white eye with less symptoms. They cannot express their symptoms also. So by the time they reach us, it is usually a chronic one. So pediatric uveitis is itself a very challenging topic. Thank you for enlightening us with that.
So may I now invite Dr. Ghazal Patnaik to go ahead with her talk on approach to a case of intermediate uveitis. Dr. Ghazal, please.
Because the time is only, discussion time is only 6 minutes, so we'll have at the end.
Very good evening. So, my purpose, thank you. At the outset, I would like to thank All India Ophthalmological Society for giving me this opportunity to talk in Teachers Talk in Uvea session. So, my motive for this subject would be to impart a basic knowledge to the postgraduates and the DNBs so that they have a clear mind to approach any case of intermediate uveitis. So the first question that pops up in our mind is that whether it's an intermediate uveitis or a pars planitis, the nomenclature. So the history begins with cyclitis by Fuchs in 1908, and it gradually evolved to intermediate uveitis by the IUSG group, that is International Uveitis Study Group, in 1987. So we have all heard about IUSG definition and Sun Working Group definition. Basically, they all tell that these are idiopathic inflammatory syndrome that involves anterior vitreous, peripheral retina and the ciliary body. There could be minimal or no anterior segment or chorioretinal signs. There should be a presence of peripheral vascular sheathing, but that should not change the classification. So what is then this pars planitis? Is it a different entity? So basically in the recent era, IUSG has come up, Sun group has come up with another classification, that is intermediate uveitis, pars planitis type, intermediate uveitis, non-pars planitis type, and intermediate uveitis associated with multiple sclerosis. So basically pars planitis is a form of intermediate uveitis when there is an absence of any associated infection or a systemic disease. A brief note on epidemiology. In India, it is found to be first 9.5, gradually increased to 17.4, and now it has been documented to have 30% epidemiology. In children, it is approximately 25%, usually presents in teens to 40s of age. Bilaterality is seen in 70 to 90%, and there is no gender or race predilection. Little bit about the etiopathogenesis. The exact etiology is not known. Basically, it is a T-cell mediated disease, and an unknown antigen is known to be an initiator. It could either be an infectious antigen like in syphilis, or could be an autoimmune like in multiple sclerosis and sarcoidosis. Basically, vitreous, as we all know, constitutes type 2 collagen, and this collagen has been noted to be an autoantigen in some patients. So these are basically 95% of the vitreous cells, and of them 35 to 90% are CD4. The second most common is the macrophages. So pathology, we see two terms, that is snowball and snowbank. As can be seen here, the white arrow shows snowball. They are composed of epithelial cells and multinucleated giant cells. Snowbanks histologically are collapsed vitreous, blood vessels and the fibroglial cells. That includes fibrous astrocytes, scattered inflammatory cells and lymphocytes. Symptoms: floaters, mild blurring and mild photophobia. Very uncommonly, pain and redness. Signs from anterior to posterior: conjunctiva mild congestion could be present, anterior chamber no or minimal reaction due to spillover, cells and flare, KPs and posterior synechia could be present. The hallmark, however, remains the vitritis. So we will learn about vitritis. It consists of vitreous cells and vitreous haze or flare. So cells, it is practically not possible, but for theory purpose we have to learn the grading. Then comes the vitreous flare. As can be seen in the down photographs, 0 means there is no flare. You can clearly see the disc and the blood vessels. 0.5 very little haze, but the details are visible. 1% if there is clear optic disc and vessels, but there is hazy nerve fiber layer. 2 plus hazy optic disc and hazy vessels. However, 3 plus only optic disc is visible, and 4 plus even the optic disc is not visible. So coming to the signs, as we discussed, snowballs and snowbanks. So snowballs are seen something like this, white, roundish, yellowish white roundish balls like structures, especially in the inferior quadrant. And when these exudates accumulate inferiorly, then they form something like banks. So this is snow banks, and it has a tendency to move 360 around the periphery and could be seen in inferior, superior, temporal, and any quadrant. Here we have to see that retinal changes are also possible, like tortuosity in arterioles, venules, sheathing of peripheral veins, neovascularization, and even retinal detachment. Why? Because these snowballs, as we learned in the histology, contains fibroglial structures. So that can contract and cause retinal detachment there also. So now we come to diagnostic criteria. How do we now diagnose this to be a case of intermediate uveitis? Basically vitreous cells, one. Second, snowballs and snowbanking. And third, in chronic cases, sometimes complications like cystoid macular edema, band-shaped keratopathies, occlusio pupillae, they can point towards intermediate uveitis. After diagnosing a case of intermediate uveitis, what all do we investigate? First, it starts with ocular investigation. So you do an FFA, you can see a sheathing of blood vessels around the periphery or throughout the fundus, and you should do a B-scan ultrasonography that can show the number of vitreous echoes, the vitreitis, that is the hallmark. Then coming to ultrasound biomicroscopy, in cases of chronic uveitis, when the pupil is very small, you cannot see the posterior structure, then this imaging comes very handy and can show presence of pars plana membranes. OCT, very important tool because we can detect cystoid macular edema, that is the main cause of visual impairment in these cases. Coming to the systemic investigation, I won't go details because if you suspect a particular disease, you go ahead with the particular investigation. So if you suspect TB, you do a Montoux and radiology. If you do suspect sarcoidosis, you go ahead with the simultaneous systemic evaluation. Coming to the complications, n number of complications starting from cystoid macular edema, cataract, glaucoma, hypertony, calcific band-shaped keratopathy, especially in juvenile idiopathic arthritis, associated uveitis, and RD as we discussed. So now we have done with diagnosis and the complication. Now comes to the treatment. It starts with medical and surgical. So it constitutes of corticosteroids, immunomodulatory therapy, now recently biological therapies, and if you have a spillover anterior uveitis, can go with topical treatment. Surgical treatment are very rarely done nowadays. It includes cryopexy, pars plana vitrectomy, and surgery. I won't go into details because of the time constraints. So we have all learned about the Kaplan's 4-stage approach, which is very historical. Now it has come to modified Kaplan's 5-step approach by Forrester. So what he says that first you try with periocular steroids, especially if it is a unilateral condition, and then if IVTA is an alternative, if it fails, or is it if it is a bilateral condition, then you go with the oral corticosteroid. If both the conditions fails, then you go ahead with the systemic immunosuppressive with immunomodulatory therapy. If everything fails, then you can go with cryotherapy or indirect laser photocoagulation to the peripheral retina. If all the above treatment fails to control the inflammation, then only pars plana vitrectomy has to be resorted. So to in nutshell, first step, you have to rule out whether it is an infectious, whether it is an immune mediated pathology, or it's an masquerade, and then you see whether it is an unilateral condition, if it is associated with cystoid macular edema, or there is no cystoid macular edema. If there is no cystoid macular edema, you can go ahead with the topical treatment with corticosteroids and NSAIDs. If it's an cystoid macular edema and active unilateral, you can go ahead with the posterior subtenon. If there is a good response, you can continue with that after 1 month interval. However, if you require 3 or more such injections, you can consider an intravitreal dexamethasone implant. If If there is no or minimal response with the PST first injection, then you can go ahead with IVT as an alternative treatment. But if you see a snowbank, you can very well go ahead with cryotherapy. If you see if it does not respond, then you can go ahead with vitrectomy. But if recurrence happens, then systemic corticosteroids. However, if you see a bilateral condition at the beginning, you should start with systemic corticosteroids. However, if the patient does not respond well, or if cannot be maintained on 5 milligram of prednisolone, then you can switch to immunomodulatory therapy and then to biologic and can consider vitrectomy. So now when should we stop the treatment as well? So if there is no clinically significant vitritis, there is no leakage on FFA, or there is no CMA and OCT for at least more than 3 months, then you can consider to stop the treatment. Then the most important thing is the cataract surgery. When do we consider cataract? We cannot go ahead with any intraocular surgery in this condition when the inflammation is active. So inflammation should be well controlled as much as possible, especially 3 months minimum. In cases of known recurrent diseases or with chronic CME, Ozurdex injection can be combined. Oral corticosteroids are usually started 4 to 7 days before the surgery, and if there is any contraindication, periocular injection can be considered. A subconjunctival injection should be injected at the end, and intensive topical corticosteroid mediatics should be started after the surgery. So at the conclusion, I would say, if you say a vitreous cells, snowbank, snowballs on vitreous cells, you should go ahead with an ancillary imaging, FFA or OCT, and a thorough systemic evaluation. With this, you should be able to clinch a diagnosis of intermediate uveitis and a proper treatment algorithm as discussed. And I hope after this, all the postgraduates should be able to approach any patient coming with intermediate uveitis. Thank you.
Thank you, Dr. Ghazal. With that, we move over to our next talk by Dr. Tomar, immunosuppressive agents in uveitis.
So good evening, everybody, once again. So the ultimate aim in the management of uveitis is to achieve the complete remission, and that we acquire either by the means of topical steroids or oral steroids or depot injections or IV infusions. But we all know that steroids are associated with the plethora of adverse effects, starting from the dermatological manifestation to the neurological manifestation, and here actually comes the role of immunosuppressive agent. But this is the area where ophthalmologists fear to trade, because this is really very difficult, that when to use, what to use, and how to use. So if it's a severe side-threatening inflammation which is not responding to appropriate steroid regime, or if patient is experiencing steroid-induced side effect, or as soon as you are reducing the dose of the steroid, the disease is coming back, that means the steroid dependence, at that time we will have to start immunosuppressive agents. And there's a long list of absolute and relative indications of immunosuppressive agents. But before starting that, you will have to decide that whether there is steroid resistance is there, or dependence is there, or related side effects are there. And first and foremost important thing is that it should be non-infectious in nature. Only then you will have to start this immunosuppressive agent. There shouldn't be any systemic contraindication to all these agents, and should have a friend in the medicine department. So if any adverse effect comes, he can take care of all these adverse effects. And before prescribing them, always have an informed consent to avoid medico-legal hassles. Baseline investigation should always be done to rule out any hidden infection inside the body or any other thing. And we have an n number of drugs in our armamentarium of immunosuppressive agents, starting from antimetabolites to biological response modifiers. The unique thing regarding this group of drugs is that anyhow they inhibit nucleic acid or proteins or both, and that's how they work. Now coming one by one, methotrexate is a very common drug which we all know, but it takes around 3 to 4 weeks to produce effects, and the major adverse effects are hepatotoxicity, pulmonary fibrosis, and myelosuppression. And if myelosuppression is there, we should take care of leucovorin rescue. You cannot give methotrexate more than 20 milligram orally, because after that the absorption is really poor, so it is better to switch over to subcutaneous infusion, and you cannot give more than 50 milligram. Before starting methotrexate, always have a drug history because there are drugs which can inhibit the metabolism of methotrexate, thereby causing toxicity of methotrexate. Azathioprine is a very safe drug, frequently used in base hits, multifocal choroiditis, serpiginous SOVKH. The onset of action again takes a longer time, so always start them with steroids. Go for CBC at 2 weeks interval and LFT for 1 month interval. And if your patient is having gout, reduce the dose of azorin because it can cause azathioprine toxicity. Mycophenolate mofetil, it's a very safe drug, very effective in pediatric uveitis, very well tolerated because the majority of the adverse effect of mycophenolate is diarrhea and weight loss. But if your patient is on steroids, please don't prescribe antacids because antacids reduces the absorption of mycophenolate mofetil. Cyclophosphamide belongs to the nitrogen mustard group, and this is the drug of choice in vaginous granulomatosis and polyarteritis nodosa associated scleritis or vasculitis, and this is the only immunosuppressive drug which induces immune tolerance to a particular antigen, so you can try an antigen priming 24 hours before starting cyclophosphamide. Major adverse effects are myelosuppression and sterile hemorrhagic cystitis because of exposure to the acrolein. So it's really very important that your patient should be well hydrated if you are prescribing oral or if you are prescribing IV infusion. I personally prefer IV infusion because IV infusion offers rapid induction, transient neutropenia, and avoid prolonged bladder exposure to the acrolein. Cyclosporin is a T-cell inhibitor usually used in combination with low-dose steroids. The initial dose is 5 mg per kilogram body weight per day, but if modified cyclosporin is used, you will have to reduce the dose by 20%, that is 4 mg per kg body weight per day. The major adverse effects are nephrotoxicity, neurotoxicity, hepatotoxicity, hypertension, and gingival hyperplasia. But the question is which one to use. So for this, you will have to understand the pathophysiology of the disease. If it is sympathetic ophthalmitis, the disease is mediated by T cells, it is better to go ahead with the cyclosporin rather than going with the methotrexate. Are you familiar with the adverse effect of the drug? And what are the adverse effects of the drug? Whether that is suiting to your patient or not. If your patient is alcoholic, he is having some liver disease, you cannot go ahead with the methotrexate. So you will have to decide accordingly. But sometimes what happens that even starting all these drugs, you cannot get complete remission. Then should we leave that? No, never give up. Then we are having biological response modifiers in our armamentarium. These are unique drugs which are directed particularly against an antigen or a cell surface receptor. We have TNF alpha inhibitors, interferons, immunoglobulins, and various interleukins and CD receptor inhibitors. TNF alpha inhibitors, we know etanercept and infliximab is there. TNF alpha and beta both are inhibited by etanercept, but we don't prescribe in uveitic patient because there are the reports of development of de novo scleritis, uveitis, optic neuritis, and myositis. Infliximab is very much useful, but there are the production of antibodies against infliximab, but that can be reduced by starting methotrexate prior to the infliximab infusion. Major adverse effects are drug-induced lupus, TB, opportunistic infection, and lymphoma. Interferon, these are a very unique subset again. They are produced by our body and they are immunomodulatory in nature, antiviral, anti-proliferative properties. Major adverse effects are flu-like symptoms and nausea, diarrhea, and neuropsychiatric manifestations. In base hits, we use interferon alpha 2A, whereas in the cases of multiple sclerosis, there are multiple cases reported which suggest that interferon beta 1A is having definitely a role. Immunoglobulins, these are the drugs which helps in autoimmune diseases without affecting any immune system or suppressing immune system. These are indicated in autoimmune ocular inflammatory disorders, and since these immunoglobulins are procured from the various donors, so the chances of transmission of blood-borne infections are very high. Now there is an era of monoclonal antibodies. We all know very much clear about tocilizumab because of COVID, but this does not cause reactivation of tuberculosis. So the take-home message is that judicious use of immunosuppressive agent is site-saving. Tailored lab investigation and informed consent is a must before starting treatment. And in the management of uveitis, you will have to achieve complete remission. Thank you so much.
Thank you, sir. Any questions?
We'll discuss
I
at the
would
end.
like to ask one question, sir. Like, do you prefer doing a TPMT deficiency test before starting azathioprine in any patient, or?
Very sad to say, in my state, we don't have that facility that I can go ahead with that test.
Do
Sorry to
you,
say.
sir, from the dais, Dr. Debashish, sir? Like TPMT deficiency, do you test before starting azathioprine in any patient?
Even if it's not done in even in the other advanced countries also, and even if you do it, this is a very costly drug, a costly test, and it doesn't really is 100% assure you that is TPNT test with the TPNT negative also that gives protection against it. So typical thing is that close monitoring of the total WBC and platelet count will be good enough.
And second question would be, what is your preferred drugs during pregnancy? Immuno.
If you will go ahead with these immunosuppressive agents in pregnancy, I think azathioprine is a safer drug.
Yeah.
According to the trimester, like first trimester, second trimester, and third trimester.
Azathioprine per se is very safe in all the trimesters. Actually, we are having that fetal medicine department in SGPGI, Lucknow. So most of the time I refer those patients for their evaluation, and in SLE patients particularly, I have a few SLE patients. So they have started azathioprine, and those patients responded very nicely.
And during lactation also, sir? Lactation period?
Lactation period you can give.
Because these drugs are secreted in milk also.
Yeah,
so
definitely.
Yeah, yeah.
But if the disease is controlled, you can stop. But with that, since you have asked the TPMT, one thing I would like to say that when we start methotrexate and we are monitoring those SGOT, SGPT titers, actually they are giving us a false sense of relief. Because if you are prescribing methotrexate for a longer duration, then it is better to go ahead with the biopsy of liver. Because the disease, this drug is very much prone to cause hepatic fibrosis. And your SGOT, SGPT titers can be normal. I have landed in a soup with one patient,
So
that's why.
after how many years of this continuing methotrexate, at what dose do you recommend doing a biopsy?
After 2 years.
After 2 years of
Yeah.
methotrexate, 15 milligram.
Yeah. Yeah, that is 50 milligram or 2 years. I will always suggest, because one of my patient that was having LFT was perfectly within the normal limits, but that patient developed somehow.
Any take on this, Dr. JB sir? Like sir is recommending, if you are using 15 milligram per week methotrexate for 2 years continuously,
No.
you should be doing, better to do a liver biopsy, not be biased with the SGOT and SGPT levels.
No, I don't do that. People taking methotrexate for years together, almost like 10, 15 years.
Yes.
Years.
Recommendation for doing liver biopsy is 15 milligrams per week for 5 years continuously.
Fine.
Then after 5 years you will do. And if one biopsy is negative, then you repeat that after 2 years if the thing continues to be on that. And there is solid, robust data from our rheumatologist. You don't need to have any conjecture on it. This is in place.
Okay. It's a great discussion. Thank you so much. Moving on, I would like to invite Dr. Shomshila Murthy ma'am to educate us on episcleritis and scleritis, the practice guidelines. Over to you, ma'am.
Thank you very much, Ghazal. Actually, I had to go back and get my computer because the pen drive wouldn't work. So I apologize for missing some of the session. And this time I thought I'll focus more on episcleritis, which is bothersome to us in a small way, bothersome to the patient in a big way. And we know in our minds, we have the dialogue ready that what it is, but the patient is not satisfied. I'm sure all of you must have faced many of these patients of episcleritis in your practice. So what is my approach? So first of all, I make sure that the focus of inflammation is episcleritis and it's not missing scleritis. And let's see what we know about this disease and some predictable clinical features to help, if we are in doubt, to distinguish between the two. And then the investigations. So it also depends on where you practice. So if you're practicing in, if I go to my secondary center where I go in the rural area, and the patient comes to us first, then you can just simply start treatment. But sometimes when they come to tertiary care, so they do expect something different from what the local ophthalmologist, who's often been on the right track, they do expect something different. So depending on where the patient is, sometimes I might investigate just for the patient's satisfaction or for the referral doctor's satisfaction. I'm not recommending that you investigate every patient of episcleral inflammation. What is known is that while in scleritis, you'll have either some history of systemic known diseases which cause scleritis. The patient will present with very dramatic symptoms. It won't be silent, it won't be shy. The patient will have a lot of pain, which is waking them up from sleep and so on. And the eye will be very deeply congested. Whereas in episcleritis, the patient is very bothered because of the appearance, but the typical feature is, and when you ask them that does the pain wake you from sleep or how severe it is, you find out that it's not very severe. They often don't even have to take painkillers. They have mild tenderness. So even if they're very disturbed by the disease, it doesn't mean that they have severe pain. So you must always distinguish between the two. And the test that I like very much in the clinic is, because anyway we do dilate and we're going to examine them, is the phenylephrine test. When you put it on all those red-looking, angry-looking blood vessels, most of them will just blanch out, will just fade away. So here was a patient who had recurrent, for years, episodes of the eye getting red and patient using some or the other drops or not using drops, and it just becomes quiet. And then when you ask, is there pain? The patient says, I have pain. Sometimes it's very severe. So then you also get in a doubt whether it's scleritis or episcleritis. So when the patient comes to clinic, we just put the dilating drops, and except for this vessel, which is a normal congested kind of a vessel, you see that there's a little bluish hue here also. So sometimes you visit scleritis, you actually wonder. But this patient never ever went into symptomatology of scleritis. This was episcleritis and just recurrent every time that you would stop whatever minimum medication you were using. So in the examination finding for scleritis, you often have this brownish hue. So it is less dramatic and sometimes it's pretty subtle. So you shouldn't miss that. But the pain and the other symptomatology is very, very classical. So what else is known about episcleritis? That some cases are associated with systemic vasculitis and connective tissue diseases. For example, I've had known patients of rheumatoid arthritis presenting with recurrent episcleritis, known patients of Crohn's disease presenting like this. So it's always a reverse side that in my experience I've had. They have some disease and they come to us with episcleritis. In my mind, I can't really think of any dramatic case where the patient came to me and I diagnosed the patient to have a systemic disease. Then the next thing is that many ocular conditions, local conditions, can be misdiagnosed or misinterpreted as episcleritis. So they'll have congestion like episcleritis, but the problem is not in the body or anywhere else, but it's in the eyelids, eyelashes, or cornea, or many other conditions can have it. And the best part is that we know that the episcleritis will never cause vision loss. So if you have a patient with recurrent redness and having loss of vision, then you know you're dealing with something else. There's something else for the lack of vision, the loss of vision. So what is a little less known, and this is, I'm not very sure, depends on how much literature you read, but these are all the diseases that I mentioned, just a couple of them, but these are all the diseases that the patients can present with recurrent episcleritis. Also there are many more, which includes herpes zoster, herpes simplex, systemic I'm talking about, and psoriasis and so on, atopy, rosacea, even ocular rosacea, and drug reaction. So the patients on certain drugs can have recurrent episcleritis. So in pediatric patients, it's by itself extremely rare, but if you see that recurrent episcleritis, it can be a few older children who are having rheumatoid arthritis. Otherwise, it's extremely rare entity in pediatric patients. If you have so-called recurrent episcleritis, it's bound to be blepharitis or allergy or something else. So bottom line is, what I've learned over the years is look for masquerades of episcleritis, benign masquerades. And one of the commonest new one or semi-new one is a very simple one. It's Demodex. So all these patients who over the years we used to treat as episcleritis, just put some drops, they get better, they come back again. Now look at them anew, look at their lids and their lashes, and you'll pick up greasy scales, and you'll pick up other findings, small little SPKs on the cornea, some old scars here and there, non-specific findings, and that turns out to be Demodex. We've also shown that by taking out the eyelashes, examining under microscope. Now we are so sure about the diagnosis, we don't even bother to do that. We simply treat the patient, ask them to do scrubs with diluted tea tree oil, and that usually, and what they had for years, it just gets better over a few weeks. And then many other conditions around the eye, as I mentioned earlier, for example, simple exposure and so on. The rare associations, and there is one more association which is a sort of a malingering. It can be either the patient is malingering or it can be a Munchausen syndrome by proxy where somebody in the family is putting something toxic in the patient's eye. So just watch out for these very odd situations, and all of you must have faced malingerers or those who put something in their eye. They have a slightly different persona and personality. So the way they come to you, you sort of, you get some alarm bells if you're old enough in your practice that this is not the normal kind of case that you're dealing with. And another patient that I wanted to mention about lid disease is in the chronic meibomitis. So even those patients can have recurrent episcleritis. So nowadays we have various ways to image the meibobin orifices. I've just kept this short, so I didn't put any case examples here. So it comes to the last question I had that about investigation. So should you investigate? I used to never investigate because first I used to investigate a lot for all sorts of diseases. Then I realized that none of them correlated. Then I just stopped investigating till colleagues would say that we've also done nothing. If you also do nothing, then how will you treat how will I explain or justify to the patient? So then I started doing a minimum set of investigations for the patients based on if they had any systemic kind of symptomatology, or did they fit into a classical clinical picture? There's no point wasting their money. And then how do I manage these patients? Typically, I have a round of medications that I use once I've ruled out all other conditions. It just revolves around topical lubricants, topical NSAIDs, then low potent lubricants or full potent lubricants. And it keeps rotating in these four medications, and a lot of vocal counseling, lots and lots of vocal counseling. And if the patient still doesn't agree, then I tell them to do vague things which won't harm them. And this is my tip for today. So vitamin D3, B complex levels, thyroid hormone, ask about smoking, ask about all these things. Something is going to be abnormal, so at least you can gently suggest that get your D3 levels tested, and maybe you need, because almost everybody is D3 deficient these days. So a lot of counseling is required for these patients. Certainly, if they don't have any of this serious entity, which is they don't have scleritis. So that's what I wanted to explain, that for me, episcleritis is very common. There are multiple etiologies, but it is very innocuous. Very rarely you want to start a patient on oral medication. I would really go out on a limb if I have to start methotrexate for an episcleritis patient. In my mind, then that patient already is labeled in my mind as scleritis. So that could be just that straddling entity between episcleritis and scleritis, only those patients. And I feel that it's very important to deal with the two very separately. Episcleritis in our mind is very innocuous, but of course to the patient we give full attention. And scleritis is sort of a dangerous disease. So they both need different thought processes. Thank you very much.
Like the take-home message was, episcleritis is bothersome for ophthalmologists more than the patients, because they keep on bugging like why it is recurring again and again. So maybe it's not a very huge disease that may cause. It might be a local ocular lid pathology that might be causing it. Another important thing is phenylephrine test that comes in the PG questions. So, ma'am, 2 words. Amitabh sir, would you like to say about phenylephrine test? At the end, okay. Okay. So now I would like to invite Dr. Mohit Dogra, who would be speaking on targeted biopsy in uveitis. Over to you, sir.
Thank you, ma'am. Thank you. And thank you for the opportunity. I hope I stick to time, and if I don't, I'll just cut my slide short then. Until this is playing out, I think just wanted to make a couple of quick points regarding what has already gone by. So we at PGI in Chandigarh, our rheumatologist colleagues do offer TPMT prior to azathioprine to most patients who can afford it. It's not that if patients don't get it done, they are not started on azathioprine, but yes, if the enzyme's not there, then they do not give them azathioprine. So we've been doing TPMT, offering it to all patients, but 10 to 20% patients are the ones who are the actual takers for it. But we do offer it to all patients, again, solely based on our experience with our rheumatology colleagues who we work very, very closely with. And one more point before I get into my talk, I think this is regarding that headlight in the fog case, that pediatric tubercular/toxo. So to my mind, we'd actually published from PGI about 4 years back now of pediatric tubercular uveitis in ocular immunology inflammation. If you were to go through that, you'd actually see a couple of cases, illustrated very similar to the ones that you had. So pediatric tubercular uveitis is different, and without wasting too much time, just would like to, with folded hands, suggest everyone to go through that paper, and I think the answer to that conundrum in that case would be solved. And with that, I come to targeted biopsy in uveitis. I can get it to work. Yeah. Yeah, thank you. So biopsy in uveitis could be a targeted extraocular biopsy. If it's not extraocular, it could be extra, as in it could be a conjunctival biopsy, it could be a AC tap, aqueous, it could be a vitreous biopsies, subretinal, chorioretinal, it could be a diagnostic enucleation. So a targeted extraocular biopsy is typical if you want to, diagnose someone as having sarcoidosis or, with tuberculosis. You could do, depending on your signs in the eye, request the pulmonologist to try and take a, sample from, various different sites in the body, and that can help. I think most of us know that. Again, quickly, going past just a small example of how an ocular exam can actually dictate a targeted extraocular biopsy and lead to diagnosis. The 35-year-old male had a gradual, drop in vision, 6/18, both eyes, had family history. His father had died at a, very similar age. He had multiple neurological issues, his supinator jerks and ankle jerks, and, all of those were off. And this is what he had. He had, I don't know whether it's showing up there or not, but had, typically if Dr. Somshila were here, she'd actually be able to point out those sago grain-like deposits. They were actually there in both the corneas, had those typical glass wool-like opacities just in the retrolental space, and did not have, the media was grade 1, but had what looked like a very, like a very moderate NPDR kind of appearance on fundus examination. And long story short, we actually got the, our clinical suspicion was amyloidosis. The patient underwent a fat pad biopsy, abdominal fat pad, which was negative. A sural nerve biopsy, however, showed that this patient had, FAP. And, although we couldn't do much for him, but, just to show how a targeted ocular examination can also lead to, at your behest, a targeted extraocular biopsy, which might lead to a particular diagnosis and not beating around the bush. A conjunctival biopsy, again, not getting into how it's done or what it could lead to, because I want to focus a bit more on the retinal and the vitreous biopsy. But this patient actually had rheumatoid arthritis, also had stage 0 CLL. However, the biopsy actually showed. I'm going to just skip to this. You can actually take a biopsy out of those, from that fleshy area, and the entire prognosis and the staging of the CLL changes. Coming to, the indications of vitreous biopsy, vitreous, subretinal, or chorioretinal, if time permits, in uveitis, which is, quite frankly, my specific area of interest. So you can have the indications for vitrectomy in uveitis can be diagnostic, therapeutic, but not looking at the therapeutic ones for the purpose of this talk. Basically diagnostic ones, and you typically want to enter the vitreous cavity if there is diagnostic dilemma despite clinical exams, serological tests, and imaging, or there is a very high suspicion of an infective or a neoplastic etiology, or there is rapid deterioration of vision despite despite what you think you're doing right. And the outcome is not marrying with what you think is the diagnosis, or you have unequivocal or ambiguous diagnostic vitrectomy results, then you want to go a step further and maybe incise or excise a part of the retina. Just going to skip that. This is some of our published work on this topic. I'm just going to come to one case, and hopefully through this try and show how a diagnostic vitrectomy works. This patient was suspected of having a primary vitreoretinal lymphoma. You can see the amount of vitreous haze. The initial vitrectomy is begun under air infusion, because you want a diluted vitreous sample. The cut rate is reduced to 800 cuts per minute, and about 1.5 to 2 ml of the initial vitreous is actually taken out and aspirated under air for an undiluted vitreous sample, following which the BSS is switched on, and then you can take a bigger sample of the vitreous and actually clear up the whole amount of the vitreous. As you do, you also need to induce a PVD, which I haven't shown in this because of lack of time. And in this patient, I had this dull yellow patch just temporal to the fovea, which will be soon seen on the blown up image. and I'd actually went ahead and taken a subretinal biopsy, which is fairly simple to do. Just a routine endocautery, and then using a passive soft tip attached to a 2 cc syringe, and mind you, passive, not active extrusion attached to the machine. And you enter with that into the subretinal space and passively allow the cells to walk up through the capillary, via the capillary action into the hub of the 2 cc needle. And what that does, I think I'll be showing in the subsequent slides. So that is basically that. And you, do a fluid head exchange, do endo laser, and I close this patient with 18% SF6 gas tamponade. So typically, both the undiluted and the diluted vitreous showed that, those amount of cells, which are scanty, right? And the subretinal aspirate, the one that I've taken, had shown, actually shows that. So not only is the yield more, but the morphology of the cells is very well maintained, hence no ambiguity in diagnosis. And you can go ahead and stain them with appropriate stains. And this patient actually turned out to be CD20 positive and had a diffuse large B-cell lymphoma. So this is one of the ways and a few of the steps that you need to do to take a vitreous and a subretinal biopsy. And if time permits, this maybe would be my last case. And I'm going to show how you might want to take a chorioretinal biopsy in certain exceptional circumstances. This has some kind of video. So this patient actually presented to us having been given Ozurdex elsewhere. And this patient, I think, at the outset had infectious retinitis, which with Ozurdex in the eye, it just spread all over. I'm just going to finish in 1 minute. And by the time we took this patient up for vitrectomy, you can see there is so much of wet heme, and all of that is the hyaloid, which is fibrosed and thickened. And it looks like you're almost cutting the retina, and this is not a uveitic case, but a diabetic case, but trust me, it is a uveitic case. So after cutting that, thickened hyaloid and trying to get, some semblance of view of the retina, which you'll soon see that I was able to get, then you try and locate a junction which is extramacular, but involves a part of the active, retinitis. So that you can see is the optic disc that I'm passively, getting the blood off, and all of those are the multifocal areas of necrotizing retinitis. I did some laser in the area that I did not want to excise first, and then settled on one of the areas there, which I wanted to excise just half a minute and then through, and actually earmark it with a mixture of cautery and confluent endo laser. And so it was actually, part of the tissue was healthy, was what looked like healthy retina, and part was the diseased retina. Made a separate port, went in with a 20 gauge old school vertical scissors, and actually cut out part of the, again, as I said, what clinically looked like diseased and non-diseased retina. And this patient did go on to show that this had toxoplasma. So just going to not look at other causes of, other things on that. Thank you.
Thank you, sir. At the interest of the time, I would like to invite Dr. Jyotirmay Vishwas, and this would be the end of the session with pulse in uveitis. By the time he starts the discussion, would like to thank Dr. Mohit Dogra sir to wrap up such a malignant talk in just 5 to 7 minutes. Over to you, sir.
The topic given to me is the pulse of uveitis. I don't call it pulse, but I want to tell the nuggets of uveitis which I have learned, and I will be sharing some cases only. Case 1, 30-year-old female, immunocompetent, and you can see that necrotizing retinitis with hemorrhages in the posterior pole. Now I ask all the audience that anybody can tell the diagnosis of this case. Necrotizing retinitis with hemorrhage, posterior pole, immunocompetent. Okay. It's not difficult. If you look at the patient as a whole, you can get the clue. And what is the clue here? The patient's forehead had got vesicles, herpes zoster vesicles, and the patient had actually varicella zoster virus retinitis. And the patient responded with a course of intravenous acyclovir for 7 days. You can see that the right eye lesions is markedly regressed and left eye is almost gone. So look at the patient as a whole in addition to a slit lamp and indirect ophthalmoscope in a room light on is quite important in uveitis. Case 2, this was a case referred from Mumbai, 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis, HIV positive, treated with intravenous ganciclovir, thinking that is a CMV retinitis. I used to shake hands with all patients routinely before the COVID era, of course, but I found something wrong in his hands. What I found? What is that? There was a rashes, syphilitic rashes was there, and my diagnosis was not difficult. I could find out that there is a exudative retinal detachment and subretinal precipitates over there, and that is suggestive of syphilitic retinitis. RPR and TPHA came positive, supporting my diagnosis, and treated with intramuscular penicillin, and after treatment, complete resolution of the inflammation. Syphilis is often a one-time disease, and you can, if you can make a diagnosis, you can make a really a vision-saving diagnosis, and this can really bring back joy to the patient and to you also. It was an accidental finding, shaking the hands so you get the clue, but you should have a prepared mind what you are doing and what you are finding. Case 3 is also interesting. 47-year-old man, pain, redness and swelling for 2 months, diagnosed as tumor with intraocular extension, advised radiation and brachytherapy, referred to our institute for the same. And if you look at that one, you might think that it's a nodular scleritis, another nodular scleritis or scleral tumor, but there is no indentation artifact, only indentation, no intraocular mass lesion, homogeneous mass arising from the episclera and sclera. So the clinically nodular scleral inflammation, we did all workup for autoimmune related inflammation. But what else you want to add now at this stage? You have finished autoimmune related inflammation, you have finished most of the other things, tumors, UVM doesn't show anything. What it could be? RA factor ANA negative, C ANCA, P ANCA negative, VDRL was positive and RPR was positive and TPH was positive. What it turned to a nodular scleritis actually is a nodular syphilitic scleritis, and with benzathine penicillin is shows complete control of inflammation. So this was published, this was a rare situation, masquerading as an ocular tumor, but sometimes you need to think out of the box also and to make a diagnosis. So everything, it doesn't fit anything, everything comes negative, you need to think about syphilis, which can mimic any type of the eye disease. Case 4 is also interesting. 30-year-old male came from USA and they labeled it as a serpiginous choroiditis. Metamorphosis in both eyes, and you might be thinking that, okay, it has come from a bigger institute and there's a serpiginous choroiditis. You look at the patient carefully, it doesn't have the really a geographic border and it's pinkish in color. So I suspected something wrong. I did an ultrasound, simple ultrasound, and ultrasound clinched the diagnosis. What is it? What is the diagnosis? Choroidal osteoma. And CT scan clinched the diagnosis, choroidal osteoma. So it was a choroidal osteoma. Always keep an open mind. Don't be carried away by some diagnosis made by somebody else, even if it is a higher institute. Case 5 is a painless gradual dimness of vision, 9 months, 57-year-old lady. She was diagnosed as an Apex Institute as a TB choroiditis with ATT given 6 months. But if you look carefully, there was a leopard skin-like lesions in between the yellow lesion. And it is a very subtle sign, But if you look carefully, it indicates that there is not really a choroiditis. So I suspected lymphoma. I told my clinician to go ahead for doing a fine needle aspiration biopsy, and I was correct. The fine needle aspiration biopsy showed necrotic background. Lymphoma cells always have necrotic background. They are friable cells, and in between that, there is a large lymphoma cells were seen. And 6 months after, the patient developed CNS lymphoma. So be mindful of even a subtle sign, and that can give a clue. Case 6 is a 35-year-old man, dimness of vision for 1 month, diagnosed as choroiditis, treated with high dose of oral prednisolone. But if you look carefully, this may not really look like classic choroiditis. But anyway, you should do a fluorescent angiogram, isn't it? And we did a fluorescent angiogram, and what I found, there is a multiple like CSR. So it's a diametrically opposite diagnosis, and the treatment is completely different, and steroid is contraindicated in CSR, multiple like CSR. So lesson learned, always do an FFA in all cases of active choroiditis. Last case. This is the last case, 15-year-old girl, sudden blurring of vision in the right eye. Vision was counting finger at 50 centimeters. Diffuse KPs studied over the cornea, some of them were quite large. I thought of span uveitis due to the TB or sarcoid. So this is the picture. I couldn't see the fundus. But I was all the time suspecting that there may be something wrong because the vision was not correlating. And at the earliest opportunity when I looked at the fundus, I did the AC tab for PCR for MTB thinking the TB, and it came for a positive for MPB64 gene for TB. I put the patient on anti-TB treatment with the topical and systemic steroid. And what happened, when the media cleared, I found there is not TB, it's a toxo lesion sitting over there. So diffuse KPs can be due to the toxo, and I learned that lesson. So it was toxoplasmic retinochoroiditis. I didn't do the ELISA for the toxoplasma thinking that it's a TB or sarcoid. That was a mistake. I was misguided with the PCR. So the lesson learned after 33 years of the uveitis practice, I am learning, and that's true. Thank you.
Thank you so much, sir. This type of pearls could come from you only. And due to interest of time, we would like to wrap up the session.
No, I think already GB sir has wrapped the session. He has given all the clues. Open, keep your mind open. Don't be carried away, and think out of the
And
box.
still learning.
And
And learning process
and
continues.
we are still learning. Thank you. I think
Thank you.
that's the end of the session.